Good evening, everyone, and welcome to the 2021 Gastroenterology and Hepatology Board Review course. My name is Deepthi Dronam Raju, and I'm a clinical assistant professor of medicine in the Division of Gastroenterology and Hepatology. My co-director for the course is Dr. Kian Kiashian, who is a clinical associate professor of medicine, also in the Division of Gastroenterology and Hepatology. We're so happy to have you join us for this 3-day live webinar intended to provide a comprehensive overview for those who are preparing for either the initial certification or recertifying for the gastroenterology and hepatology boards. In addition to the content of this live webinar, you all also have access to pre-recorded lectures that are available to you through the Stanford CME website. Just a few housekeeping items before we begin tonight's webinar. We are utilizing Zoom for this weekend's course. And on this next slide, you'll see a screenshot of what the Zoom webinar window looks like. I really want you to focus your attention to that bottom black panel at the bottom there that has 3 buttons, the chat, the raise your hand, and the Q&A button. These are the main features that you'll be using throughout this weekend's webinar. The chat box is going to be the main feature that we use to communicate with our hosts at the Stanford CME staff. If you have any technical issues, you will use this chat button to communicate directly with the CME staff, and they can assist you directly. If for any reason you're having difficulties submitting your question through the chat box, you can use that middle button or the raise your hand feature, which will alert our host that you're in need of assistance. We just ask that once you've been assisted, that you click the button again so that you lower your hand so that we know you've been helped. That last button, the Q&A button, is the main feature that you're going to use to communicate with our speakers throughout the course. And this is how you'll ask questions for the speakers. So when you click on that button, it brings up a text box. You're able to type your question into the text field there. And once you do that, you're able to send the question either with your name, or you can click the button and send it anonymously, whichever you prefer. Great. Here are our faculty disclosures. And we are giving both CME and MOC credit for this course, and you will be getting more information about how to claim credit for the course in the chat feature and at the end of the weekend on Sunday. Lastly, we will be using Poll Everywhere to answer polling questions during these 3 days of the live webinar. In order to access Poll Everywhere, you can go to pollev.com/gastro2021 on any mobile device, tablet, or laptop in order to participate. You can also click on Gastro 2021 and text Gastro 2021 to 22333 to join. You can also download the Poll EV app to your phone, whichever you prefer. So before we start, just to kind of get everybody warmed up on how to use Poll Everywhere, we'll start with a few questions. So if you could all download the app and make sure you have access to it. The first question is, what is your favorite color? Red, blue, purple, yellow, or green? So again, you want to make sure you download that app. You can either text to Gastro 2021 to 22333 or download that app or use that website. So we'll wait for a few more people to see if they're able to log on. We have 2 people who've been able to use it. Okay, I guess other people may be still trying to log on. So we can check the responses. So most people chose red and somebody chose green. So we have 1 more question to practice. So again, please make sure that you're able to log on to pollev.com/gastro2021 or text gastro2021 to 22333 in order to join. Great, we've got more people joining in now. Okay, we can move to the next question. Are you zooming in from California, yes or no? You can see that people are answering, so we'll give it another few seconds. Okay, let's go to the next slide and see how people answered. Most people seem to be from California, and a few people are from elsewhere. Great. Okay, we can go to the next slide. So I'm going to now hand it over to my co-director, Dr. Kian Kiashian, who will talk to you more about preparing for and taking the GI board exam.
Great, Deepti, thanks a lot for that introduction. And I'd like to extend another welcome to you all for joining us. Thank you. This is, we're looking for, it's going to be an exciting weekend, and we look forward to hopefully answering some of your questions, interacting with you as well in this virtual setting. So we're going to spend about 10 minutes, 15 minutes talking a little bit about preparing for and taking the GI board exam. We can go to the next slide. So the main GI organizations, the American Gastroenterology Association, American Society of Gastrointestinal Endoscopy, and American College of Gastroenterology have put out studying tips for getting yourself ready for the boards. And the first and most important thing that you've got to be thinking about doing is to review the breakdown of content areas. And the big hint here, of course, is hepatology. We'll talk a little bit about some of the breakdown of the actual test from the ABIM website, but hepatology has to be a part of it. And expect questions on cirrhosis, drug-induced liver injury, metabolic liver disease, and viral hepatitis. Pregnancy is a popular topic on the boards, including pregnancy and inflammatory bowel disease and liver disease and acid reflux. Also pay attention to hereditary colorectal cancer syndromes, and I direct you to a great talk by Yuri Lauterbaum, and he will be available on Sunday to answer additional questions about that. What's important to realize is that the latest and greatest in the past year will likely not be on the test. So guidelines are useful, reviews are useful, but really focus on those from 2 to 3 years ago. They're not looking for the latest evidence, and they probably won't test you on the latest evidence. But good reviews from a couple of years ago are probably still valid today for the most part, and so I would consider those in addition to other tools that you're using. We can go to the next slide. So here's a nice breakdown of the test from the ABIM website, and you can see here that there is a focus on the liver, 25% of the exam being liver-based. The colon, stomach, duodenum make up the next set of portion of the content, followed by the remainders, esophagus, biliary tract, and pancreas, and small intestine making up the rest. So I think it really is very reasonable to study all of these areas, but if there's a particular area you're weak in, particularly liver, make sure that you spend some time on that, because that is a significant portion of the content of the test. So what are the additional studying tips? Things that we're familiar with. Don't cram the night before, but it's okay to review key points. And remember that lab values are generally provided on the test. As you're doing practice tests, the organization suggests noting deficiencies and focusing on studying there. Remember that these questions on the test are not going to be looking for the exception to the rule. So the key is not to overthink these questions and think about how they might be tricking you. They're generally looking for the rule. And so I think this approach can make it make testing a bit more easy, straightforward, but also the practice tests will provide meaningful review for you. So as far as the practice tests, identify specific questions and in the answer choices, identify distractors. If you were wrong, why were you wrong? And you can practice pacing. This is what practice tests will accomplish. And as far as those wrong answers, think about the topical areas, maybe make a note of that, and it might help you in deciding what areas to go back and spend the last bit of studying to do. Think about whether you made a logical guess or you really had no clue. That might help in your focusing of studying. And did you study this and forgot it, or was it something that you didn't study at all? And I think those are all sort of approaches on what you can learn in these practice tests from wrong answers. So on the day of the test, I encourage you, and some of you have already done this, but do visit the abim.org website and move on to exam day. And so, always a good idea to understand the correct documentation that you need, clarify what, and of course, some of this is, different in the setting of the virtual setting with respect to these exams, but regardless, you want to make sure that you've sort of entered all the important pieces that you need to enter. clarify what you can and cannot have, plan your snacks, your breaks. If you're home, locate your restroom, but otherwise, certainly some important test taking, day of the test kind of reminders. And then as far as the test length and some resources that can be used during the test, there's a couple of options at this point, right? There's the 10-year maintenance of certification exam, which has 240 single best answer questions and 55 experimental questions that may not count. There's a knowledge check-in now that's available every couple of years, which is 90 questions and can last 3 hours. And remember that access to up-to-date is allowed. So if you haven't used this tool, become familiar with the search function. You can even enter keywords from the question string to help you in looking through up-to-date. And certainly scroll down to the bottom of up-to-date of the review for tables, graphics, links to other topical areas which may contain the content if you're not able to find it in the page that you've pulled up. Additional guidelines, what about on the day of the test? Well, certainly answer every question before proceeding. There's really no penalty for the wrong answer. And it's okay to mark challenging questions. You can make the notations on the notes window or an erasable board. And if you do go back to a question and you change an answer, have a really good reason to change an answer. Oftentimes our first gut instinct may be the correct one, but certainly make sure that you answer all the questions because there's no penalty here. If you're unable to finish, fill in all the answers and use a consistent letter. This is just general good test taking advice, not necessarily specific to the ABIM GI boards, but some things to consider as far as questions. Certainly read all the answers, read the answer choices, keep track of time, and pay attention to the nuances of the case. There's probably a reason why, even though previous questions may not have asked it, why gender, occupation, recent travel may be noted, as it might be relevant for you to help figure out in terms of where to go. All right, so I think with that summary, I'm going to introduce our faculty for this first part of this evening. Dr. Andres Gottfried Blackmore will be the moderator, and we appreciate him taking part in that role. Additional panelists will be Patricia Garcia, Juha Huang, George Triada-Philopoulos. Dr. John Clark will also be joining us. He may be a bit late, but Dr. Garcia will be taking some questions as well, but related to his topical area. And so without further ado, Dr. Gottfried, I'd like to hand it over to you.
Thank you, Dr. Keshian, and welcome everyone to tonight's session on the disorders of upper gastrointestinal tract. We'll be mainly covering disorders of the esophagus and the stomach tonight. And I'd like to introduce my colleagues briefly. Dr. Triada-Philopoulos is a clinical professor of medicine. His research interest concerns factors involved in the pathogenesis of gastroesophageal reflux disease and its complications, such as Barrett's esophagus, and the role of diagnostic and therapeutic modalities in their management. Dr. Juha Huang specializes in early detection of gastrointestinal malignancies, including esophageal cancer, gastric or stomach cancer, pancreatic cancer, bile duct cancer, and colon cancer. Dr. Huang performs advanced endoscopy procedures, including upper endoscopy, EUS, FNA, ERCP, and enteroscopy. He also performs oral endoscopic myotomy of the esophagus and the stomach, and resection of large polyps and other lesions. He has both a clinical and research interest in improving early detection of gastric cancer. He's a fellow of the American Society of Gastrointestinal Endoscopy and past president of the Pacific Northwest Gastroenterology Society. Dr. John Clark, who will be joining us later, is the director of the esophageal program at Stanford University. He previously spent 17 years in Baltimore, including 9 years on the faculty at Johns Hopkins, where he was associate professor and at various times director of the esophageal motility, as well as director of the gastrointestinal motility center at Hopkins. He's lectured in many countries and authored several book chapters, and being on educational affairs committees for the ACG. Dr. Patricia Garcia is a board certified GI, and she's a fellowship trained neurogastroenterologist. who specializes in treating disorders of gastrointestinal motility, including dysphagia, reflux disorders, constipation, fecal incontinence, and pelvic floor dysfunction. And myself, I have a background, I'm a physician scientist with a background in neuroimmunology and inflammation, which I'm applying to trying to understand upper GI motility disorders, and my practice is focused on gastroparesis. So with that, I'll be reading our question stems and moderating this session. So for our first question tonight, we have a case of a 64-year-old man who has been diagnosed with long segment Barrett's esophagus with a focus of carcinoma in situ on biopsy specimens. He also has a history of morbid obesity, diabetes, and emphysema. Cross-sectional imaging of the chest and abdomen is negative for metastasis, and endoscopic ultrasound showed superficial nodular mucosa in the distal esophagus, but did not demonstrate any enlargement of local lymph nodes. The patient expresses a preference for aggressive treatment. So the question in this stem is, what is the most appropriate management for this patient? A, referral to a thoracic surgeon for esophagectomy. B, referral to a surgical oncologist for esophagectomy with colon interposition grafts. C, endoscopic mucosal resection with radiofrequency ablation of the Barrett segment. D, endoscopic submucosal dissection of the entire Barrett segment. Or E, repeat surveillance upper endoscopy in 1 year. So using the poll app, we'll be taking answers for this. We have 4 answers so far. Maybe we'll give it a few more seconds for attendants to respond. And for those of you joining us just now, you can join the response system either by entering the web address at the top of the slide, pollev.com/gastro2021, or you can use your phone and text gastro2021 to the number 22333. So perhaps we'll, I think we have 22 participants, but we've only recorded 5 answers. So maybe we can go ahead and review the answer for this question and give a chance to participants as we discuss the answers. So most people, 60% of respondents answered C, endoscopic mucosal resection with radiofrequency ablation of the Barrett segment. And this is the correct answer. And for those of you who chose referral to thoracic surgery for esophagectomy or endoscopic dissection of the entire Barrett segment, perhaps we can have one of our panelists, Dr. Triadafilopoulos, share why these were not the best answers for this patient.
So endoscopic submucosal dissection of the entire Barrett segment, it is not a great idea because it leads to significant amount of scarring, and you will replace a Barrett segment with a huge structure that goes up and down the entire esophagus that will lose its pliability. So it's not the preferred approach here. The repeat surveillance upper endoscopy in 1 year is not an option here who has, the patient has carcinoma in situ. One could debate referral to a thoracic surgeon for esophagectomy, especially if the endoscopic mucosal resection is not feasible in a particular area or a particular hospital. Typically, that's the answer in particularly nodular abnormalities that suggest the presence of underlying high-grade dysplasia and carcinoma in situ. And that's followed by radiofrequency ablation of the remaining Barrett segment. And that's why this was the proper answer on this question. Juha, do you want to have any points that you want to make on this particular question from the
Yeah,
advanced?
I mean, the current ASGE guidelines and as well as the AGA guidelines would support this particular answer. And this kind of gets back to Kian's initial recommendations where he says, don't overthink it, because, you know, certainly with large, depending on the size of the nodular mucosa, one could argue that the patient should have ESD, but it wouldn't be ESD of the entire segment as George mentioned, because that would result in a significant stricturing of the esophagus. The challenging part of this question is it states that the patient wants very aggressive therapy. And again, with that, you know, one could argue that, you know, having an esophagectomy would be the most aggressive form of therapy. But the standard of care right now and the recommendations based on, you know, fairly well-established guidelines would be to do EMR of the of any nodular Barrett's that suggest high-grade dysplasia or carcinoma in situ, and then you must also ablate the residual Barrett's because there's a high risk of cancer then developing in that in the remaining Barrett segment.
Absolutely, and a proper evaluation of the Barrett segment with meticulous attention to any kind of nodular or even ulcerated area has to take place, so you know what you're dealing with and you know where the main enemy is, and address that first, followed by the overall residual ablation of the Barrett segment.
Excellent, thank you. If attendants have any further questions on this particular case, please submit them through the chat option on the Zoom. So we'll move on to the next question. I guess this was an explanation slide related to this question. And it explains the risk factors taking into account the presentation and risk for cancer and advanced disease. Again, the disease phenotype, prior treatments history of the patients, and possible treatments going forward. And as Dr. Huang mentioned, patient preferences, but also adhering to the standard of care. Okay, so let's move on to the next question. This case is of a 34-year-old otherwise healthy man presenting for pre-op evaluation of fundoplication. His esophageal manometry revealed a basal lower esophageal pressure of 20 millimeters mercury and an integrated relaxation pressure, or IRP, of 5 millimeters mercury. The distal latency was noted to be greater than 4.5 seconds in all 10 test swallows. The distal contractile integral, or DCI, ranged from 500 to 1000 millimeters mercury per second per centimeter in 4 swallows, 200 to 300 of this unit in 2 swallows, and 30 to 60 in 4 swallows. Finally, the manometry showed peristaltic break was less than 5 centimeters in all swallows. Next slide. So based on these manometry findings, which of the following is the most likely underlying cause? A, diffuse esophageal spasm. B, tumor at the EGJ junction. Chronic opioid use. D, jackhammer esophagus. Or E, gastroesophageal reflux. And again, we'll be using the Poll EV app to submit our answers.
Andres, is it possible to go back and forth so the audience?
So we could see the, yes,
Yeah.
we can see the findings on the manometry. Yes, if we can go back on a slide. I don't know if it's gonna, oh, yeah, there we go. Thank you. So this is a challenging question because it requires us to have a basic understanding of some normal range manometric findings, which we will discuss in detail as we move forward. Okay, I don't know how many respondents have answered. but it looks like, okay, this is 7 responses. I think we're still not capturing the majority of the audience with the response system. So again, if you've just joined us, please log into the web address polev.com/gastro2021. You can do this on your phone, your laptop, or computer. Or you can use your phone and text Gastro 2021 to 22333. And then you'll have the answer system on your screen. Okay, so why don't we move forward and review the answers. So all the respondents able to respond chose gastroesophageal reflux. Here we have 1 respondent, a couple more responding A. Okay, now we're capturing some more answers. This is good. And I think we're fine with time. We've actually started a little bit early, so there's no hurry. Looks like some folks are changing their minds. Okay, why don't we move forward? So that I think we skipped a slide, but the right answer is E, or gastroesophageal reflux. And if we move on to the next slide, we'll be able to discuss the answer for this. And I'll invite Dr. Patty Garcia to help us navigate the manometry findings.
That sounds good. And if we could go back to the question, it might be easier just as we talk through the actual metrics. But this question is definitely tricky. And I think that it's the kind of question where if I wasn't a motility expert, I might be tempted to guess and move on because there are a lot of nuanced things that you need to know. But I think including it as part of tonight's session is good because it gives us a chance to maybe review some of the things that are a little bit low hanging fruit without you needing to memorize all these numbers. The other thing that makes this question tricky is that in addition to needing to know the metrics and the criteria for the disorders, you also have to know what things cause motility disorders. So let's start with the first metric here. It says that the lower esophageal basal pressure is 20 and the IRP, or the integrated relaxation pressure, is 5. So both of those are normal. It's saying that the sphincter pressure sits at about 20, which is normal, and that when it opens to a pressure less than 5, which is normal. And you might even be able to intuit that an IRP of 5 means that that lower pressure is pretty low, and that there's no evidence of outflow obstruction. So options B and C were tumor and opiates. So opiates, we now know, cause outflow obstruction. So you can sort of scratch tumor and opiates off because that lower sphincter looks like it's opening. Next, it says that the distal latency is greater than 4.5 seconds. So distal latency is what we use to define spasm. And if you think about spasm, when the esophagus spasms, it's basically these early simultaneous contractions in the whole body. And so the distal latency is the metric that sort of tells us how fast are contractions happening after swallowing. So if the esophagus is contracting after 1 second, then that's kind of this spastic simultaneous contraction. And 4.5 seconds is what defines normal. Anything more than 4.5 is normal. So in this case, that's telling you there's no spasm. And then the last part is giving you a range for distal contractile integral. So the distal contractile integral is basically how strong the esophageal contractions are. And what this is telling you is that 500 to 1,000 millimeters of mercury times second times centimeters, basically the volume of the mountain that the esophagus is sort of creating, that's normal. So it's saying 4 swallows are normal, 200 to 300 is weak. So 2 of those are weak, and then 30 to 60 is absent. That's sort of not enough to be counted. So in this case, they're telling you that 60% of the swallows are weak or absent, and 40% of the swallows are normal. So up until January, that would have qualified for ineffective esophageal motility. And then the last piece that you need to know is that the classic cause, or one of the classic associations with ineffective esophageal motility, is gastroesophageal reflux disease. So in this case, the manometry diagnosis is IEM and reflux is the association. Now, I'll tell you the potentially good news is that this won't be on the boards because the criteria just changed for IEM. And if we could go to the slide that had the Chicago classification on it, the Chicago classification is what we use. It's the criteria that we use to define motility disorders, and it gets updated, and it was just updated in January. And this is the current version of the Chicago classification, but I think what's probably helpful for you to know is that they're probably not going to test you on things that just changed. So the definition of IEM just changed, and just so you know, it went from you need 60% of swallows to be weak or ineffective to you need more than 70%, so 80% or higher. So it got more stringent. The other thing that changed is the way in which we talk about and define esophagogastric outlet obstruction. So those two entities are potentially less likely to be tested on in terms of the criteria, like these numbers. Now, the way in which we define achalasia, the way in which we define hypercontractile or jackhammer esophagus, the way in which we define spasm, those all stayed the same, and they're probably still fair game. I think the other thing that's fair game is just without the specific numbers and percentages, knowing these associations. So knowing that opiates are associated with outflow obstruction, or knowing that reflux is associated with ineffective esophageal motility, those concepts are probably still fair game.
Thank you, Dr. Garcia. Again, any questions, please feel free to post them on the chat question option of our Zoom. Okay, so we will, and I just want to mention, one attendee asked if we could put the question stem and the answer options on the same slide on our Zoom. What we are recommending is the best way to accommodate this is if you're able to download the Poll EV app on your phone or mobile device, you'll be able to see the answer choices on your phone, and we'll keep the question on the Zoom. And this way you can see both question options and the options at the same time. Okay, so let's move on to the next question. In this question, there's a 28-year-old woman. She presents for evaluation of postprandial fullness, early satiety, and epigastric pain. These symptoms occur 15 to 30 minutes after initiation of a meal. She denies any heartburn, reflux, regurgitation, chest pain, or vomiting. She underwent evaluations, including an upper endoscopy that was unremarkable. Gastric biopsies obtained were also normal. She completed a 2-month trial of twice-daily proton pump inhibitors that did not result in any change in her symptoms. A gastric emptying scintigraphy performed showed 99% emptying at 4 hours, and an abdominal ultrasound obtained did not reveal any abnormalities. She later completed a wireless motility capsule study that showed normal gastric, small bowel, and whole gut transit. So if we move on to the next part of the question, is which of the following is the best options to be considered as the next step in therapy? Option A is buspirone, 10 milligrams before meals. Triple antibiotic therapy for H. pylori infection. Referral for surgical evaluation for cholecystectomy. Metoclopramide, 10 milligrams before meals, or initiation of a high-fat, high-fiber diet. So if we're able to launch the option on Poll EV and then go back to the question stem, that would be great. So we'll record answers. And again, the options are to initiate buspirone, 10 milligrams before meals, to do triple antibiotic therapy for H. pylori, to refer for surgical evaluation of a cholecystectomy, to treat with metoclopramide 10 milligrams before meals, or to initiate a high-fat, high-fiber diet. And why don't we see what the responses are so far? So the majority of attendants answered correctly, buspirone 10 milligrams before meals. And if we go to the question again, and one person responded, or some folks responded metoclopramide. So the diagnosis here is a functional dyspepsia, which has a lot of overlap symptoms to gastroparesis. But in this question, there's no vomiting. And importantly, the gold standard for diagnosing gastroparesis is delayed stomach emptying on scintigraphy, which was absent in this patient. So this patient showed 99% emptying at 4 hours, which is basically complete emptying. Delayed emptying starts at least 10% retention at 4 hours. In terms of the other options for this question, triple antibiotic therapy for H. pylori is not indicated. The patient had an upper endoscopy, which had normal findings, and gastric biopsies were obtained, which did not show H. pylori, so that is incorrect. Surgical evaluation for cholecystectomy is also not the best answer, given that patient had a right upper quadrant ultrasound, which again did not show cholelithiasis or cholecystitis as indications for surgery. Metoclopramide is the appropriate therapy for gastroparesis patients, but this patient does not have gastroparesis. And finally, a high-fat, high-fiber diet is actually might actually exacerbate symptoms, because patients with functional dyspepsia can have visceral hypersensitivity to fats and fiber in the duodenum. Anything else that my colleagues might want to add to this question? Nope. Okay. Again, if you have any questions, please type them out and we'll try to address those as they come in. So let's move on to the next question. Oh, and let me just spend 30 seconds on this slide. So buspirone is considered a neuromodulator. Neuromodulators are now considered standard of care for many of our functional motility disorders of gut-brain interaction. And these include buspirone would be an anxiolytic. It's actually a serotonin receptor antagonist. We also have other medications, including tricyclic antidepressants, SSRIs, SNRIs, and NMDA receptor antagonists like gabapentin and pregabalin. So this is what this slide is invoking, and why buspirone is now part of our arsenal to treat patients with functional dyspepsia. Okay, so we can move on. Good. So this next question is about a 32-year-old male who presents for discussion of his family history and genetic test results. The patient has no personal history of cancer and reports no gastrointestinal symptoms. The patient reports that his mother, however, developed lobular breast cancer at age 35. His maternal uncle died of diffuse gastric cancer at age 42, and his maternal grandmother also had gastric cancer at age 52 years, although the histology of his grandmother's cancer was not known. The patient's mother underwent genetic testing that revealed a mutation in CDH1. The patient had genetic testing himself and was found to carry the same mutation. So the question is, what is the next best step in management? A CT of the abdomen and pelvis. B, an upper GI study. C, refer to surgery for total gastrectomy. Or D, endoscopic ultrasound. So we have a young, healthy male with significant family history, including mother with breast cancer at young age, a maternal uncle who's died of diffuse gastric cancer in his early 40s, and a maternal grandmother who had gastric cancer in her 50s. And the mother and the patient are positive for carriers for a mutation in CDH1. So I think we can look at the responses. Okay, so we have the majority of respondents are going to refer this patient for total gastrectomy. Some would like to do an upper GI study first, and some are opting to do a CAT scan of the abdomen and pelvis. The correct answer for, oh, here we go. So maybe we'll leave a few more seconds. Although the distribution of answers seems to be holding, with a majority still for gastrectomy. This is the correct answer, surgery for total gastrectomy. And perhaps Dr. Juan can illustrate why this is the best answer in this question.
Yeah, if you want to go to the next slide, I think the next slide, we discussed this. So this patient has a CDH1 mutation, and this is part of the hereditary diffuse gastric cancer syndrome. This is an autosomal dominant disease with 70% penetrance. So these patients have an extremely high risk for going on to gastric cancer. So the correct answer to that is to refer the patient for surgery, because the recommendation is to have a prophylactic gastrectomy between the age of 20 to 30. If the patient absolutely refused and said that they wanted to hold on to their stomach as long as possible, then you could pursue very aggressive endoscopic surveillance, but that's still not recommended, because with this type of diffuse gastric cancer, oftentimes the lesions aren't really mucosally visible. The median age of diagnosis for gastric cancer in patients with CDH1 mutations is is about 38, with a range of 14 to 82 years of age. There are other gene mutations that also are related to or part of the hereditary diffuse gastric cancer group, and they include CTNNA1, which is alpha-catenin, BRCA2, which is associated with breast and ovarian cancer, and then STK11, which is associated with Peutz-Jeghers. There's other more minor ones, but obviously the major one is CDH1. This almost always shows up on the boards. So definitely know about CDH1, the E-cadherin mutation, and that the recommendation is for prophylactic gastrectomy at the age of 20 to 30. With the pathology, there might be a question that's related to the pathology. These are often signet ring cell types due to abundant intracellular mucin, and it is not the intestinal type. So there are two different types, or a few different types of gastric cancers, but the hereditary diffuse gastric cancer and the intestinal type gastric cancer are different entities. And so if there's intestinal type histology, it is not hereditary diffuse gastric cancer. And endoscopic surveillance should be performed annually in confirmed carriers who are younger than 20, and then over 20 for those who wish to postpone surgery. So that's kind of the nutshell on hereditary diffuse gastric cancer.
Thank you, Dr. Juan. Okay. Again, if our attendees have additional questions, please feel free to text them and we can bring them up in the discussion. Moving forward, the next question is a 25-year-old woman with significant heartburn, regurgitation, and dysphagia despite use of twice daily proton pump inhibitors presents for esophageal function testing. The 24-hour pH monitoring performed off acid suppression showed a total acid exposure time of 6.2%, and the normal is less than 4%, so this is mildly elevated. A Demeester score of 30, and here the normal range is less than 14, and a significant symptom association probability, or SAP, for both the heartburn and the regurgitation events. The esophageal manometry is shown below and revealed the following findings for all of the test swallows. So the question is, what is the most appropriate next step in the management of this patient? A, refer for Nissen fundoplication. B, schedule Botox injection to the lower esophageal sphincter. C, schedule endoscopic pneumatic dilation. D, lifestyle modification. And E, start a calcium channel blocker daily. So we can go back to the question so people can see the manometry. And we'll see the answers in the Poll EV app. And for those of you who are not logged into the Poll EV app, I'm going to repeat the options. A is referral for Nissen fundoplication. B, schedule a Botox injection to the lower esophageal sphincter. C, schedule endoscopic pneumatic dilation. E, lifestyle modification. Or last one is start a calcium channel blocker daily. Okay, let's see the distribution of responses. So we have about a third of participants referring for Nissen. Nobody's enthusiastic about a Botox injection to the LES. A few participants have think a pneumatic dilation, it would be pertinent. Okay, now we have a Botox injection answer, and the majority, however, is opting for lifestyle modifications. So the correct answer to this question is D, lifestyle modification. And we can have Dr. Garcia shed some light on why this is the best answer.
Okay, sounds good. Maybe we can put up the question again. I think the first thing that hopefully a lot of you picked up on is that this patient has acid reflux. He had a 24-hour pH test, which showed a total acid exposure time of 6%. And they sort of are giving you the normals, which is good. So you know that normal is less than 4%, so he's got a lot of acid. He's got a Demeester score of 30.1, and the Demeester score is a composite score that tells us about a lot of different factors, not just the total amount of time that there's acid exposure, but when there is acid exposure, how long does it last? When does it occur? In what positions? And it creates a composite score that also tells us about the likelihood of reflux or the significance of reflux. And in this case, again, they give you the normal value, that normal is less than 14.7 and he's 30.1. And then the last thing they tell you is that he has a significant symptom association probability for both heartburn and regurgitation. So you have a lot of acid, a high Demeester score, and positive symptom association. So you know the patient has reflux. And then, just kind of using those test taking skills, if you know the patient has reflux, then Botoxing the LES or dilating the LES is just going to make it even weaker. And that junction is going to be even more relaxed or more dilated. So you're going to get even more reflux. So that's a bad idea. And then calcium channel blockers also relax the smooth muscle esophagus. There's something that sometimes we do when people have spasms. So again, you're going to have even less peristalsis, less contraction, and even more reflux. So you can sort of rule those three out right away. And you're left then with Nissen versus lifestyle. Again, like test taking skills, it's always going to be on the lifestyle side. Like it's usually like the herbal approach or the least dramatic approach in my experience. But in this case, what they really want you to know to arbitrate between those two is this manometry. So what you're seeing here in the manometry is absent peristalsis and a weak lower esophageal sphincter. Even if you don't know a whole lot about manometry, you can tell by looking at this that there's just nothing going on in the esophagus. So the patient has absent peristalsis, and this pattern is something that we see in people with scleroderma or other connective tissue diseases, although certainly sometimes we just see it and we don't know why. And so what you need to think about here is if the patient has a really weak esophagus and you do a Nissen, which is a very tight wrap around the bottom of the esophagus, the chance that that person is going to have post-operative dysphagia is quite high. They're not going to have enough push to push through this new wrap. So even though in somebody with reflux, Nissen is a good idea, we recommend, and hopefully this is happening more places than not, that everybody gets a manometry before something like a Nissen so that you catch this before the patient ends up with postoperative dysphagia. So that's why in this case, the answer would be lifestyle modification. The other thing I wanted to just take a second to talk about, and if you go forward to the the slide with the colorful boxes, I just wanted to take a second to talk about the way in which we use esophageal tests to establish the likelihood of GERD. So what you're seeing here is a representation of something called the Lyon consensus, which is a paradigm based on evidence and expert opinion about how we should define GERD. So what you see at the top, those orange boxes, this is conclusive evidence of GERD. If you see this, you know they have it. So that's grade C and D esophagitis, Barrett's, and peptic strictures on endoscopy, or if you do some sort of pH testing and the acid exposure is greater than 6, you're done, it's reflux. Borderline evidence is LA grade A or B esophagitis, because we know that these are sort of very subjective visual inspection findings, or acid exposure between 4 and 6%. Again, sort of going back to that original slide, less than 4% is normal. So if you're in that 4 to 6%, it's sort of borderline, or an increased number of reflux episodes. So these are sort of borderline places. So you get these test results and you say, do they have reflux or not? And that's when you look to this adjunctive, these blue boxes, to sort of help you decide yes or no. There are some histopathological features that can be helpful to define reflux, although looking at electron microscopy is probably not something that we're all getting or doing very often. Mucosal impedance is a very new kid on the block. So this is probably less likely the kind of thing that you're seeing, unless you're doing kind of very subspecialized motility testing or motility centers. In the pH testing box, though, there are some other features. So symptom association, if they have kind of borderline exposure, but every time they have heartburn, it's reflux, that kind of makes you think, yeah, this is clinically significant. If they have a lot of reflux episodes and a couple other really sort of specific reflux criteria, and then manometry findings. So if they have a hernia, which we know is associated with reflux, or a weak sphincter or a weak esophagus, all those things kind of lead you towards the path of, yeah, reflux is probably what's going on. And then the green box is sort of the evidence against, right? So on pH testing, if they don't have a lot of acid exposure, they don't have a lot of reflux episodes, that probably takes it off your agenda. So this is sort of the most modern way in which we define GERD, and certainly something that we use a lot in clinical practice and could be fair game on the boards.
Thank you, Dr. Garcia. And can I ask us to just go back quickly to the manometry in the question stem? Some of us don't see manometry tracings very often. So just to review the basics of the anatomy shown on the manometry slide. I don't know if, can folks see the mouse on my screen being moved around? No, probably not. So maybe just a description of
but I think
the colors
if you do control, I think if you do control and then do the mouse click, it turns it into a pointer. But I don't know if you have control. It might be because somebody else is projecting. Okay.
Yeah.
Well, I think the bottom line about this is that the sort of that top green line, that's the upper esophageal sphincter. And so what you see here is that there are little kind of spikes and then baselines and then spikes and baselines. That's basically when the patient is swallowing. So you sort of get an opening of the sphincter and then you get, sort of the tonic contraction. So what you're seeing there is the upper esophageal sphincter. And then at the very bottom, that other little pressure line, and it's kind of hard to think about manometry in an abnormal example, but that lower line is the esophagogastric junction. And I'm saying the esophagogastric junction and not the lower esophageal sphincter, because there are a couple of things that contribute to that lower pressure line. Certainly there is the lower esophageal sphincter, but there's also the diaphragm. And so when we breathe, you can see contraction of the diaphragm at that EG junction. And then there's the hiatus itself, sort of the hole in the diaphragm and how tight that is, or how much it's been manipulated. So if somebody's had a fundoplication, you may see more pressure at this line. If somebody has a hernia where it's separated, then you may not see as much pressure in the line. So those all go into that lower pressure bar. And then in the middle, you should see something. So we saw kind of, or we'll see another manometry in the future, but you should see sort of a peristaltic wave, which usually looks sort of like a red mountainy shape going down the esophagus. Here, you have some pressure at the top and some pressure at the bottom, and there's nothing going on in the middle. So that's why it's absent peristalsis.
Thank you, Dr. Garcia. Perfect. Okay, let's move on. And again, if attendants have questions, please use the Q&A box. So this next question is a 62-year-old tennis instructor who presents with chronic postprandial abdominal pain. He had been on PPI or proton pump inhibitor for 2 weeks with minimal relief. You perform an upper endoscopy and see multiple antral ulcers and erosions. A postprandial serum gastrin level is ordered and found to be around 210 picograms per ml. Question is, what is your next step for this patient? Order a CT scan, A, stop the PPI and recheck the gastrin, stop non-steroidal and continue a PPI, or last question option, order a basal acid output test. So we can use the poll app while we review the question again. So the options are ordering a CAT scan, stopping the PPI and rechecking the gastrin, stopping NSAIDs and continuing the PPI, or ordering a basal output acid test. And if we can look at the responses. Okay, so the majority has responded stopping NSAIDs and continuing the PPI. And some folks are suggesting stopping the PPI and rechecking the gastrin. And the correct answer for this one is C, stopping NSAIDs and continuing the PPI. Dr. Huang, would you like to illustrate
Sure.
why
Let's go back to this question. Yeah, let's go back to the, can we go back to the question? So I did not write this question. This is from the DDSEP, and I think it's an absolutely terrible question. But what they're trying to get at, so the first line, they don't ever tell you the patient's on NSAIDs, right? So, but it's to be implied because he's a 62-year-old tennis instructor, so supposedly they're all on NSAIDs. He's been put on a PPI, and what they're testing multiple things with this question, right? They're testing, they're trying to tease you into thinking that there's the possibility of a gastrinoma because he has multiple antral ulcers on a PPI. And then for some reason, someone checked a gastrin level. I don't know who would ever check a gastrin level in this scenario, but so that's why I think it's a red herring. They want you to understand that this is not an elevated gastrin level. So if you understand that the patient's on a PPI and has a serum gastrin level of only 210, that is perfectly within normal limits for someone on a PPI. So if it's a gastrinoma, one would have a gastrin level that is in well over 1,000. So you can rule the CT scan answer is to look for gastrinoma. So you can exclude that. The one that that might be a little bit confusing because they're having you chase the gastrin level would be to stop the PPI and recheck a gastrin level. If you are worried about a gastrinoma, that would be the right answer. But in this scenario, he does not present with anything that would resemble someone with clinically with a gastrinoma because the ulcers are in the antrum as opposed to typically with a Zollinger-Ellison syndrome, a gastrinoma, you're going to have ulcers that are in the duodenum and not just the stomach. And oftentimes you see ulceration well into the second portion of the duodenum where you really shouldn't see any ulcer. So let's go on to the explanation slide, or we can stop there. Actually, go back just to the questions. I just want to make sure that so order a CT scan, definitely not. Stop in PPI and recheck a gastrin. It sounds like a good answer, but it's not the correct answer. You needed to realize that the patient was on NSAIDs, and you would just stop the NSAIDs and continue the PPI. There's really no good reason to order a basal acid output. Next slide, please. So just quickly, again, Zollinger-Ellison syndrome, this is a popular topic for boards. It's associated with MEN1 in 20 to 25% of cases. It often causes multiple ulcers with severe gastritis, and it should be noted that the ulcers extend into the duodenum. And then they also have the symptoms of dyspepsia and oftentimes diarrhea because of all the acid that is going. It's caused by a gastrinoma. Most of the gastrinomas are in the duodenal region. and then the rest are in the pancreas. They're diagnosed by the following criteria. You want them off of PPIs for 3 to 7 days and fasting, and then you can check a gastrin level, and the gastrin level should be over 10 times or over 1,000 usually, with a gastric pH that is still low. So you want to be able to ideally check a gastric pH and show that it remains abnormally depressed. The other criteria would be to have an elevated gastrin level that isn't quite 10 times the upper limit of normal, but still have a gastric pH of less than 2, and then a positive secretin test. And a secretin test is measured pre and post secretin injection. So in normal G cell, secretin decreases acid production. In Zollinger-Ellison syndrome, gastrin increases due to activation of the tumor. So this directly comes from the DDSEP9, and I don't think that the question would be written the way it is, but I certainly would understand the association between gastrin and PPIs. It's a very popular topic to address.
Thank you, Dr. Huang. Okay, moving on. Next question is, a 32-year-old male with a history of eosinophilic esophagitis has presented to the emergency department 3 times over the past year for a food impaction. He comes to you for a second opinion and reports intermittent dysphagia but no pyrosis. He is taking swallowed fluticasone for 140 micrograms twice daily and pantoprazole 40 milligrams daily. His last endoscopy 2 months ago showed a stricture at 25 centimeters, which would not allow passage of the scope. The remainder of his esophagus revealed mild linear furrowing, but no other dominant strictures or fixed rings. Biopsies of the stricture and proximal esophagus did not have any eosinophils. So the question here is, what is the next best step in the management of this patient? A, increase fluticasone, steroid dosing, basically double it. Change pantoprazole to omeprazole, rotate the PPI. Dilate the stricture using an 8 to 10 millimeter through the scope balloon. Next would be a dilate the stricture using a 54 French Savary dilator. And E is to dilate the stricture using an 18 to 20 millimeter through the scope balloon. So we'll go to the poll app and we can go back to the question stem. And I'm going to repeat the possible answers. The first option is doubling the steroids. The next one is rotating the PPI. And the next 3 are dilating the esophagus. The first option is using an 8 to 10 millimeter through the scope balloon. The second is using a 54 French Savary dilator. And the last option is using 18 to 20 millimeter through the scope balloon. Okay, let's take a look at the responses so far. So the majority of respondents are opting to use an 8 to 10 millimeter through the scope balloon. And some attendants have chosen a 54 French Savary or a larger through the scope balloon of 18 to 20 millimeters. I guess some of these are changing. We have a few opting for doubling of the steroids. Okay, so I don't know which one of our panelists would like to tackle
Me.
this one. Okay, all right, Dr. Garcia.
So it seems like most of you recognize that medication is not going to be the right approach for this patient. They're already on a PPI, they're already on fluticasone, and yet, pantoprazole is sort of like placebo, and you could argue about, whether there should be changed. But there's a couple of reasons probably not that's not the right answer. The first is that the biopsies don't seem to show a lot of inflammation. So there's not a lot of eosinophils. And so getting more of that anti-inflammatory action may not do all that much if the eosinophil level is low. The second is, once you have a stricture especially if you're already on some amount of medicine, it's unlikely that it's going to melt away. If the patient was on no medicine, certainly we've seen people with EOE have improvement in strictures once medical therapy started. But in most cases, once you have that scar tissue, medicines are going to be tough and you're going to need to do something mechanical. Now, in this case, one of the things that you need to know is the diameter of the scope. So they're telling you that the scope could not pass. The diameter of a standard upper endoscope is about 9 millimeters. And so you're saying to yourself, how do I dilate something that's that tight? The bottom two choices, so the TTS balloon, 18 to 20 millimeters, 54 French is 18 millimeters. So if you dilate a 9 millimeter stricture to 18, that takes a lot of guts. It's probably not a good idea in EOE or any other circumstance. Maybe a Schottky's ring, but usually, even then, you got to be careful, not only because of perforation, but also because in people with EOE, they can have a lot of chest pain, even gentle dilation. I think the other thing to think about too, when you're thinking about savory versus TTS balloons is in this case, they're sort of telling you that they never even saw the rest of his esophagus. So if you go shoving a savory on through to esophagus that you've never seen, especially one that's that large, the chances that you're going to perforate or cause some serious tears is high. So in this case, you want to be a little bit more, I'm not even say conservative, but you don't want to be as extremely aggressive as option D and E, and you want to just try to gently open up that stricture. So taking it from, where it probably is less than 9 to 10 is a good place to start. It gives you a chance to see how does the patient feel after dilation. Are they having a lot of chest pain like we was just going to have, or are they good? And he's probably going to have to come back for more, for more dilation.
We cannot hear you, Patty.
Oh, you can't hear me?
No,
Your audio is a little bit broken up.
it was dilated with a balloon.
Oh, let me try to change. Can you hear me now?
That's better, Patty.
I'm just going to switch my audio to my computer. Okay, is that any better?
Much better.
Oh, okay. Where was I when I was lost?
You were talking about savory dilation.
Sorry. So what I was saying about the savory dilator is that the other thing that you have to think about with savory dilators in this case is that they're sort of telling you that they haven't seen the rest of the esophagus. So they weren't able to pass this pretty high up stricture at 25 centimeters. And so, when you do savory dilations, you want to make sure that you've assessed the whole esophagus. So that, maybe there's a stricture that's, in this case, it's really tight up there, but maybe there's a stricture that's open at the top, but if you don't see the bottom and there's a tighter stricture there, when you go through with a large diameter savory and you can't really see what you're doing and you don't really know what's down there, again, you have to really worry about perforations. Now, sometimes savories are absolutely the right choices in these narrow caliber esophagus patients because they can have fibrosis of the whole esophagus, but that's something that you want to know and make a very thoughtful decision about doing because you've assessed the whole esophagus. Maybe you've dilated this dominant stricture so you can get to see the rest of it. You can see how they respond to something gentle and focused, like the TTS balloons, in this case with this one focal stricture that it's had.
Yeah, and I think the more important thing would be, it would be a typical question if they say dilate with a 30 French savory. But
Right.
They're saying dilate with a 54
Exactly.
French savory, which is 18 millimeters. So,
Yeah, the bottom two options are very aggressive for a 9 millimeter or less stricture. Not even aggressive, I'll say dangerous and sue worthy.
irresponsible.
Irresponsible.
Correct. And thank you, Dr. Garcia, for that. And one of our attendees is asking if there is an EOE expert at Stanford. And yes, we do have an EOE expert at Stanford. That would be Dr. Nielsen Fernandez Becker. And I believe she will be participating in this course tomorrow or Sunday. So moving on. This next question is a 42-year-old man presents with dysphagia for 3 months. He reports progressive symptoms, primarily with solid food. He reports a 10-pound weight loss. He has no history of heartburn. He has a 10-pack year smoking history, but quit 10 years ago. His BMI is 35. His upper endoscopy reveals a mass in the distal esophagus. The mass is 4 centimeters in length with a diameter of 1.2 centimeters. And biopsies confirm adenocarcinoma. Which of the following is true about this patient's condition? A, tumor diameter is a predictor of long-term survival. B, EUS FNA is more sensitive for nodal staging than computed tomography or CT. Next, rates of esophageal adenocarcinoma are decreasing. And D, tobacco use is the strongest risk factor for esophageal adenocarcinoma. So we'll use the poll app. Okay, so once again, options are true about esophageal cancer. Tumor diameter is a predictor of long-term survival. EUS FNA is more sensitive for nodal staging than CT. Rates of esophageal adenocarcinoma are decreasing, or D, tobacco use is the strongest risk factor. And I think we can go to the responses. Okay, so majority of attendants are responding EUS FNA is more sensitive for nodal staging than CT. And some of us are responding that tobacco use is the strongest risk factor. Dr. Triadopoulos, would you like to share with us about the answer for this question? Which is B, EUS FNA is more sensitive for nodal staging than CAT scan.
Right. Clearly, EUS FNA is more sensitive than computed tomography, which is more useful to detect distal disease or metastatic disease. The tumor diameter has nothing to do with the prediction of long-term survival. And the clear no answer is rates of esophageal adenocarcinoma are decreasing, which they are increasing, particularly in the West. Tobacco use is a risk factor in patients with Barrett's esophagus, but in this particular case, the BMI of 35 appears to be the more significant player in the induction of adenocarcinoma in this particular patient. And truncal obesity is actually an even more significant element.
Okay, thank you. Thank you, Dr. Triadopoulos. Okay, moving on to the next question.
And I just want to add
sure,
on that last question, I think more importantly that EUS is more accurate than CT for local staging. So it's not just for nodal staging, but it would be for local. So T1, T2, T3, EUS is going to be much more accurate than CT scan for staging of esophageal cancer.
Two more points on this. Juha, is obviously the issue of trying to figure out if high-grade dysplasia is related to adenocarcinoma, and you do EUS, which may not be useful. But the other thing is that the limitations of the EUS, if you have a lesion that you cannot cross with the EUS scope, which is a larger diameter usually than the conventional scope, has some limitations.
Yeah, but usually those, if it's so bulky that you can't cross it, that's a T3, T4.
Yeah.
And in those cases, then CT scan is sufficient.
Great. Thank you for those finer points. Okay, we have another manometry question. This is a 75-year-old man with a history of emphysema and tobacco use, currently on 3 liters of home oxygen, who presents with dysphagia in the last 3 months. He describes a sensation of ingested food getting stuck in his mid-chest region when swallowing, causing him to often regurgitate the food items. He has lost 30 pounds since his symptom onset. Evaluation with an upper endoscopy was otherwise normal, and an esophageal manometry performed reveals the following images. So we'll go to the question and then come back to the manometry. So the question is, what is the next step in management? Referral for POEM, B, Botox injection to the lower esophageal sphincter, C, pneumatic dilation, D, schedule chest CT, or E, start a calcium channel blocker. And we can look at the options in the poll app, and in the meantime, we can review the manometry findings again. Okay, let's look at the responses. So some of us are opting for POEM referral. Some of us are suggesting a Botox injection to the lower esophageal sphincter. And just over half of the respondents would like to get a chest CT. Dr. Garcia, would you like to review the answer for this question? Which is letter D, and schedule a CAT scan.
Yeah, so we can go back to the question just so we can see the picture. But you know, what they're trying to get at here is pseudoachalasia. So, and I think a lot of you probably picked up on this because you might be asking yourself, why are they telling us that this is somebody with emphysema and tobacco on oxygen? And, you know, I think that, again, like those test taking skills, you know, when they're giving you information like the tennis player, it's because they want you to try to kind of think of something. So in this kind of elderly person who's on a lot of O2, what they want you to think about is lung cancer and the association of, like, you know, what does lung cancer have to do with the esophagus? And the link there is pseudoachalasia. So malignancy-related pseudoachalasia can be from a tumor at the esophagogastric junction, or it can be an immune-mediated paraneoplastic process, of which small cell lung cancer is one of the most common culprits. And the way that it works is that there is cross-reaction between antibodies to tumor antigens. So kind of back to med school, you know, anti-Hu and anti-neuronal antibodies. And those antibodies to the tumor antigens also attack the neural circuit of the esophagus, which gives you a pseudoachalasia-like picture. And so what you're seeing here on the manometry looks like type 3 achalasia. So what you can see is that the bottom of the esophagus, that lower line, it never opens, you never see it relax. So that's kind of defining this outflow obstruction. And then you see in the esophageal body that there's this early simultaneous big contraction. And so, you know, it used to be called spastic achalasia, but essentially, you know, you kind of have this spasm in the esophagus combined with this outflow obstruction, and that's type 3 achalasia. Now, they could have shown you type 2 achalasia, type 1 achalasia. It's not necessarily that type 3 is the most likely in this case, but I think they're just trying to tell you that this person has achalasia-like physiology in the setting of lung cancer. And the other thing you might say is, well, maybe you would still treat this guy with Botox, and, you know, but I think what they're trying to get at is you don't want to miss the diagnosis of lung cancer when you find something in a patient that is sort of a GI sign of some other disorder. You always want to make sure that you're addressing that other disorder. So in this case, it'd be a CT scan to diagnose the lung cancer.
Thank you, Dr. Garcia. And also just the top portion of this plot is an impedance, correct?
Yeah, but I wouldn't look at that right now because it's kind of strange. I don't know why they put.
I agree. I don't know why they put it in the question stem. There's no bearing for it, but I just wanted our participants to know that top portion is an impedance trace. So this study was an impedance manometry study. Yeah.
Yeah, and it's not even how we would usually see it. It's kind of weird. I don't know why they put it there either.
Yeah. Okay, good. Any questions on this particular case? If not, we'll be moving on to the next question. So this is a 55-year-old Latino man who undergoes upper endoscopy for dyspepsia symptoms, during which several non-bleeding antral ulcers are seen on endoscopy. The biopsies of the antrum and corpus are taken during endoscopy, and the histopathology review demonstrate the following findings seen in the image below. The question is, which of the following is true regarding this patient? And we'll review the questions and then go back to the photograph. So this is a dyspepsia patient. Which one is true about this patient? Cessation of NSAID medications is the most important factor in ulcer healing. B, appropriate therapy can reduce his risk of intestinal type gastric cancer. C, the gastric injury is likely caused by iron deposition. D, partial gastrectomy is the treatment of choice for his condition. And E, repeat endoscopy in 3 months should be performed to confirm ulcer healing. So we can continue looking at the answer options through the poll app, and we can go back to the question stem. So 55-year-old Latino man having dyspepsia, endoscopy shows small non-bleeding antral ulcers, and the biopsy path image is shown in the photograph. So which one is true? Cessation of NSAIDs is the most important factor in healing ulcers. Appropriate therapy can reduce the risk of intestinal type gastric cancer. This type of gastric injury is likely caused by iron deposition. Partial gastrectomy is a treatment choice for this condition, or repeat endoscopy in 3 months to confirm that ulcers have healed. All right, so let's look at the responses from the group. Great, so the majority has answered B, appropriate therapy can reduce risk of intestinal type gastric cancer. And a few respondents chose to stop NSAIDs and monitor for ulcer healing. So if we go back to let's review the correct answer, which is B, appropriate therapy can reduce this patient's risk of intestinal type gastric cancer. And if we go back to the question stem, we can have a discussion about this with Dr. Huang.
Yeah, so this question is actually very straightforward. So it's asking you to recognize that this pathology is showing evidence for H. pylori infection. So this is a IHC or immunohistochemical stain for Helicobacter pylori, and pretty much you have a Latino man. Pretty much any minority is at higher risk for H. pylori infection. They're associated with dyspepsia symptoms as well as non-bleeding antral ulcer. So this is just a classic presentation of someone with H. pylori, gastritis, and ulcers. So if we go to the questions or the answers, so cessation of this is not NSAID-mediated ulcers like the tennis player. So these ulcers are H. pylori related. So it wouldn't matter that they're on NSAIDs. And then the other questions, gastric injury is likely caused by iron deposition. This is kind of just, it looks brown, so maybe it's iron. That's probably why that one's there. Partial gastrectomy is the treatment of choice for this condition. Not really even sure why that they would come up with that. So that could easily be excluded. Repeat endoscopy in 3 months to confirm ulcer healing. Again, if you have a large bleeding ulcer and you see that and you don't take biopsies, then absolutely you would want to confirm ulcer healing to make sure that there's no malignancy. But again, this patient isn't presenting like this. He has multiple small antral ulcers due to H. pylori. So the correct answer is that treating the H. pylori will treat his gastritis, which we know can lead to intestinal metaplasia and then intestinal type cancer along the Chorea cascade. So B is the appropriate answer.
Thank you, Dr. Huang. And again, if any of our attendees have any questions, please feel free to write them up in the Q&A option at the bottom of your Zoom tab. We're going to move on to the next question. This is a 63-year-old female patient that has a urease breath test that confirms active Helicobacter pylori infection. She reports a recent urinary tract infection treated with ciprofloxacin and was prescribed azithromycin recently for bronchitis last year. And the patient reports no drug allergies. So the question here is, what regimen would you recommend for the treatment of this patient's H. pylori gastritis? A triple therapy with PPI, amoxicillin, and clarithromycin. B, quadruple therapy, PPI, bismuth, metronidazole, and tetracycline. C, triple therapy with PPI, levofloxacin, and amoxicillin. Or D, triple therapy with PPI, amoxicillin, and rifabutin. And I don't think we need to stay on the question. We can, I guess, go straight to the responses. This is a patient who's already been exposed to a couple of antibiotics in the last year. And they're asking us which is the most appropriate antibiotic therapy for H. pylori. Okay, so most of us are opting for quadruple therapy, and a few of the respondents are opting for triple therapy with amoxicillin and clarithromycin. The appropriate response is B, which is quadruple therapy. And Dr. Huang, do you want to continue on the H. pylori topic, or do you want me to take this one?
Yeah, I mean, you can take this one, but it's pretty obvious. I mean, the patient's been exposed to erythromycin, which would suggest that clarithromycin should, there's clarithromycin resistance, and the patient has also been exposed to a fluoroquinolone. So you would want to avoid that due to antibiotic resistance, and that the quadruple therapy would make the most sense in terms of the most appropriate regimen to treat this patient with.
Agreed. And I think one of the main points of this question, which we'll see on boards, is recognizing that H. pylori has a very high rate of antibiotic resistance. And this is an ongoing worldwide problem. And so failure to respond to antibiotic therapy is becoming an increasing clinical problem. And that's why it's important to know that patients that have had prior exposure to these classes of antibiotics are at higher risk of having resistant H. pylori strains, and therefore quadruple therapy is the preferred treatment option to increase the likelihood of treatment success. And quadruple therapy should be a 14-day regimen. And in terms of option D, rifabutin, so this is an antibiotic that should be used and saved as a last resort in the setting of treatment failure or salvage therapy. Excellent. So let's move on to the next question. So this is a 78-year-old man with a history of Parkinson's and recurrent Clostridium difficile infection, presenting for the evaluation of epigastric pain, early satiety, and postprandial fullness. Patient notes that his epigastric pain remains his most severe symptom, for which he has had several presentations to the emergency room. Evaluation of this patient with an upper endoscopy revealed retained food in the stomach despite a 12-hour fast prior to the procedure. And a gastric emptying scintigraphy showed 52% emptying of the test meal at 4 hours. So the question is, which of the following treatment options is the most appropriate for this patient? A, gastric electric stimulation. B, erythromycin, 100 milligrams 3 times daily. C, initiation of a heart-healthy, low-fat, high-fiber diet. D, metoclopramide 10 milligrams before meals and bedtime. Or E, initiation of a low-fiber, low-residue diet. So we can go back to the question stem and we can enter our responses on the poll app. And for those of you not accessing the poll app, the options here are gastric electric stimulation, B, erythromycin, 100 milligrams 3 times a day, C, initiation of a heart-healthy, low-fat, high-fiber diet, D, metoclopramide 10 milligrams before meals and bedtime, and E, initiation of a low fiber, low residue diet. So let's look at the responses. Excellent. So we have a few respondents opting for gastric electric stimulation, some for erythromycin, and the majority opting for initiation of a low fiber, low residue diet. Reviewing the correct answer is E, initiation of a low fiber, low residue diet. So the question here is about getting the right diagnosis, which is gastroparesis, and then knowing what is the best initial treatment management. And if we look at the options here, so this patient has Parkinson's disease. Patient presents with the chief complaint of this patient is abdominal pain. And so these are important factors to take into account for treatment of gastroparesis. So going down the list of options, gastric electric stimulation is most effective for nausea predominant gastroparesis, not pain predominant gastroparesis. Also, it is more effective in diabetics with gastroparesis or post-surgical patients that have gastroparesis, not so much in idiopathics like this patient, although you could make an argument that Parkinson's disease is probably associated to his dysmotility. The next option, erythromycin, is an effective promotility prokinetic drug for the stomach. But an important piece of information in this question stem is that this patient has had recurrent C. diff infections, and therefore it would be inappropriate to give this patient further antibiotic exposure, risking his C. diff recurrence. The next option nobody went for, which is a low-fat, high-fiber diet. High-fiber diets are contraindicated in gastroparesis patients because fiber slows the stomach and is much harder for the patients to digest. Letter D is metoclopramide, 10 milligrams before meals. So this is actually an appropriate therapy for many gastroparesis patients, but in this case, metoclopramide has a risk of tardive dyskinesia, and this risk is much greater in patients with underlying neurologic disorders of motor disorders like Parkinson's disease. So in a patient with Parkinson's, metoclopramide would be contraindicated. And therefore, the last option is the appropriate answer, which is a low fiber, low residue diet. And this is the best answer, not just because the others are inappropriate, but also the point made here by the question is that diet is the fundamental first line therapy for gastroparesis. Diet modification is first and foremost before starting prokinetics, neuromodulators, endoscopic interventions, or gastric electric stimulation. So those are the two major salient points for this question. I don't know if any of my colleagues have anything to add.
I would add something here, Andres, which is the most common recommendation that neurologists make to patients with Parkinson's disease is basically high fiber, high residue diet, because they're fighting constipation as the leading problem in these patients. And obviously this patient is classic gastroparesis in the Parkinson's setting. And there is a possibility that the patients with Parkinson's disease have also gastroparesis coexisting with colonic inertia or slow transit constipation. And we need to be careful what we prescribe and what we're trying to fight. In this case, for example, the true answer is low fiber, low residue, but we need to do something also for the underlying constipation that these patients suffer many times, much more frequently than gastroparesis.
Thank you, Dr. Trifilopoulos. That is correct. Constipation is certainly the most common motility disorder we see in our Parkinson population, and so that's a nuance of this question. But luckily, nobody caught it as a potential answer to this particular case. Good. So we have a few more questions to go, and we've decided we're going to continue until 6:40, if that's okay with our participants. And so we'll just plow through the next few questions and see how far we get. So next question. This is a 42-year-old female with a history of documented grade C erosive esophagitis on an upper endoscopy. This patient was recently seen because of continued heartburn despite double dose PPI. A recent repeat upper endoscopy with biopsies on PPI treatment was unremarkable. The patient reports almost daily symptoms, primarily during the daytime. She has tried antacids and over-the-counter H2 blockers with no improvement. An impedance and pH test on PPI treatment revealed normal esophageal acid exposure and normal non-acidic reflux. Symptom index and symptom association probability were 50% and 98% for weakly acidic reflux and heartburn, respectively. High resolution esophageal manometry was unremarkable. So what is our diagnosis? A, non-erosive reflux disease, or NERD. B, reflux hypersensitivity overlapping with GERD. C, functional heartburn overlapping with GERD. Or D, hypersensitive esophagus. We can go back to the question stem and answer one of the options on the Poll EV app. And I believe our colleague, Dr. Clark, has been able to join us. So perhaps he will pitch in to help us get answer to this question. So
Sounds good. I'm sorry I'm late.
No problems, Dr. Clark. Thank you for joining us. So let's look at the responses. So this is a good spread. The majority of participants have chosen reflux hypersensitivity overlapping with GERD, but some of us are thinking about functional heartburn, others about non-erosive reflux disease, and some others with hypersensitive esophagus. The correct answer is B. So the majority of us were correct in this. And Dr. Clark, maybe you can walk us through this question.
Yeah, so this becomes a little bit challenging because the definitions keep changing. And this is based on the Rome 4 criteria, which came out, I believe, in 2016. And in this particular patient, because they have baseline erosive esophagitis off meds, they have GERD at baseline. So they may have GERD plus something else, but they wouldn't meet the criteria of A based upon the fact that at baseline they have erosions. On therapy, there's no sign of acid exposure despite the meds that they're on, and the reflux numbers themselves seem normal, but based on the symptom index as well as the SAP, there is symptom correlation. So this would fall into a category of B, where essentially there's both hypersensitivity as well as baseline GERD. This wouldn't be A based on the fact that we have erosions at baseline. C would be the case if there was symptoms, but no correlation. So we do see those patients with C, but the main difference here is that if that was the right answer, then the symptom correlations which were mentioned would have been negative. And in terms of the hypersensitive esophagus, they do have that, but given the baseline erosive disease, they also have GERD as well on top of the hypersensitivity.
Great. Thank you, Dr. Clark. We're going to do one more question. Thank you, everybody, for sticking around. This has been great so far. So this last question is a 35-year-old female has been having daily dysphagia, regurgitation, and chest pain for 6 months. She has no previous heartburn. She lost 5 pounds. She had no response to daily proton pump inhibitor therapy. She was being referred for workup to consider Nissen fundoplication. Her upper endoscopy with wireless pH monitoring off PPI therapy demonstrates no obvious strictures or masses. Her lower esophageal sphincter was not patulous and there was no hiatal hernia. Biopsies of distal and mid esophagus were normal. The time spent with pH of 4 or less was 7%, and the Demeester score was 25. So these are both elevated. There was no correlation between reflux and symptoms. Manometry findings demonstrated an integrated relaxation pressure, or IRP, of 22, which they say is above normal, and a distal contractile integral, or DCI, with normal vigor and no premature contractions. There were abnormal appearing swallows with repetitive contractions and compartmentalized pressurization with all swallows. A barium swallow showed no masses or strictures, and a barium tablet did get hung up at the gastroesophageal junction. What is the most likely diagnosis? A, refractory GERD with failure to respond to PPI therapy. B, EGJ outflow obstruction as a primary motility disorder. C, eosinophilic esophagitis. D, reflux hypersensitivity. Or E, functional heartburn. Okay, so why don't we take a look at the responses? Wow, so the big majority of the group is opting for EGJ outflow obstruction as a primary motility disorder. And some of our attendees think about reflux hypersensitivity. The correct answer is, in fact, B, EGJ outflow obstruction as a primary motility disorder. And maybe Dr. Tredafilopoulos and or Dr. Clark could walk us through the answer for this question.
Sure. Yeah, no, sure. So, so this patient is presenting with a few symptoms, but both dysphagia and chest pain are two prominent ones, which are often associated with motility disorders. And when looking at that, when doing manometry, the IRP is essentially a marker of junction relaxation. And so if that's elevated in both the supine and the upright positions, and you have bolus pressure above that, which is elevated, but peristalsis, which is intact, then you'd meet the definition of outflow obstruction based upon Chicago 4. Sometimes when we see this, we do sometimes see this finding with small hernias, if there's any mechanical pressure in the area. And so that would be something to think about. Chicago classification 3 was a little more loose in terms of the way it was defined. With the newer one that came out earlier this year, Chicago 4, they've tried to narrow it down a bit more. And so if it's in both the supine and upright position, and if there's also bolus pressure above that and symptoms of either chest pain or else dysphagia, then it would meet criteria as long as peristalsis is intact. So I think, this patient would fit in that category. GERD would not fit if there's no improvement with acid suppressive therapy. Sometimes we can see some of the pH numbers be a little bit high in outflow obstruction, as well as with achalasia, just because we have stasis in the esophagus there. So that probably explains these findings. We can see outflow obstruction with EOE, but the rest of the stem would point against that. Reflux hypersensitivity, if there's not symptom correlation with acid, that becomes less likely. And then functional heartburn may be present, but if there's dysphagia and chest pain, this would meet criteria of outflow obstruction.
Thank you, Dr. Clark.
Can I ask you, John, what would you do in this case therapeutically?
Yeah, it's interesting. For outflow obstruction where they've got dysphagia and chest pain, I think you could go in a couple different directions with this. As you've looked at in your paper, I think that we do find a lot of these patients with outflow obstruction as defined by Chicago type 3 can resolve spontaneously without intervention. So I think how aggressive I am and how I approach these really is based on the severity of symptoms and how hard I'm being pushed from the patient. If they're not tremendously symptomatic, it's not unreasonable to maybe try peppermint and wait and see how things go. Botox would be a reasonable option to see if that'll make a difference. And just because the natural history of this is unclear, that's often my first line step. If I'm forced to go beyond that based on severity of symptoms, persistence of symptoms, et cetera, then I do think whether it's pneumatic dilation, versus POEM versus Heller myotomy, it almost becomes dealer's choice. There's a nice paper from the group in Florida that Richter did, where they had looked at a pneumatic dilatation with about 75% improvement that seemed pretty durable. So I do think that's a reasonable option in these patients. But those patients that I have sent towards more aggressive therapies such as POEM have done pretty well. But I start with a less is more in this patient population, just because a lot of them will get better without doing anything aggressive.
Yeah, I agree with what you said. The question that I wanted to extend the initial question is, would you prefer flip or a classic balloon dilation?
Oh, got it. Yeah, I mean, I've liked flip with this, and I'll say that it's partially logistics. We don't have a lot of fluoro space here at Stanford, and we do have flip availability. So I like the fact that I can dilate to flip with 30 and do that without fluoro. And I should say actually that with Chicago classification 4 now, you can't make the diagnosis of VEGJ conclusively without doing some additional tests to try and corroborate those findings. And so that could either be a time barium esophagram versus doing a diagnostic flip. So if this fit with that scenario, what I would probably do in my own practice is do flip and just look at distensibility directly and then treat at that time as well at the same time. And one more brief thing to mention also is that this is also the classic pattern with opiates. So if you are asked a board question about this finding and what meds or what might be there, you just think of opiates also as a possible toxicity effect.
Thank you. Thank you very much, Dr. Clark. Thank you, Dr. Tredafilopoulos. We are going to wrap up this session. Dr. Dronan Maju, do you have any closing
Yes, thank
remarks?
you all for joining us. This concludes this first session. Thank you to all the panelists for being here. We hope you can all join us again tomorrow morning at 8 a.m. for hepatobiliary and pancreatic disorders, followed by liver disease. So we'll see you all tomorrow morning at 8. Thank you again. Have a good evening. Bye.